All right, well, welcome to this most recent episode of the Cod and Cocoa Report. We have John Mandrola and Bogdan and Ash here today. They are returning to the show. We've had them on individually before to talk about two separate cases on the Cod and Cocoa Report, two fantastic cases relating to ventricular tachycardia, ventricular fibrillation, two actually patients that we brought on. So I strongly encourage you folks to listen to those two prior episodes, and we'll have those on the show notes. But welcome, John. Welcome, Bogdan. Thank you so much for coming on.
Thanks. Good to see you guys.
Thank you for having me.
Absolutely. Thanks for that. Thank you for coming on. The first case we talked about was with Bogdan, and the first case is where I brought on Tom Wingard, a patient of mine who I've been seeing for some years now, who had a syncopal event after going to the bathroom, something we commonly call micturition syncope, or what seemed to be micturition syncope. And then a abnormal echocardiogram led to an MRI that was abnormal, and there's some question about how abnormal it was, and the questionable diagnosis of ARVDC. And then finally, he ended up very quickly in front of an electrophysiologist at one of the cardiology centers of repute, and they very quickly had a defibrillator placed. The defibrillator that was placed was a subcutaneous ICD, not the traditional transvenous ICD, which has leads that go inside the heart and snakes through the veins in the heart. This is a SubQ ICD that is a relatively newer defibrillator that courses in the subcutaneous tissue. The lead courses in the subcutaneous tissue, kind of around the thoracic cage. And both Bogdan and John have been instrumental in kind of pointing out some of the problems with SubQ ICDs, namely that SubQ ICDs, because the lead doesn't sit in the heart, it's a good thing in that the number of complications that you have, both placing the lead and the long-term complications, at least seem to be less compared to the traditional ICD. But because that lead is sitting outside the heart, there isn't as good of a way of the device to discriminate between tachycardias or high heart rates that are normal, where when you exercise, your heart rate goes very high, and that's normal. And when you stop exercising, slow down, your heart rate comes down. The device, if it's if the lead isn't sitting in the heart, can mistake the high heart rate for a dangerous rhythm and then subsequently shock the patient. And that, unfortunately, is what happened to Tom. And now Tom has to be very careful about what his heart rates get to. And, he's constantly monitoring his heart rate. And once his heart rate gets to a certain point, he has to slow down because he's afraid that the device that he has may shock his heart. And both John and Bogdan, along with Rita Redberg, after the Praetorian trial came out, that was a non-inferiority trial comparing SubQ ICD to the traditional transvenous ICD that led to the FDA kind of approval for the device, which allowed it to be placed in patients. They pointed out in a letter that, hey, look, there are a lot more inappropriate shocks, and using the margins that that were pre-specified, this very likely may not have met the pre-specified margins for even approval. And then later on, the device itself that courses across the thoracic cage, turns out at the bend, there may be a little defect, maybe a structural weakness, and that's led to some recalls as well. So anyhow, that's a sorry for a long synopsis of that case. But I'm curious why, the Praetorian trial came out years ago. I'm curious, John, why is it that there doesn't appear to be more uptake of the concern, the very real concern that you and Bogdan and Dr. Redberg identified?
Well, I think the subcutaneous ICD has substantial theoretical advantages in terms of not having a lead in the blood vessels. And I think most doctors, who implant these things and who follow patients understand that there are a lot of complications that come up with standard ICDs. And so there's this theoretical advantage of the SubQ ICD. And I think it really the enthusiasm for this device comes from a beneficent intent of just trying to put in a device that works equally well and may have less complications, especially in younger patients. And so I think it's really just a theoretical advantage of the device.
But again, this is why is it that in you have basically it's widespread consensus in academia and not in academia that these devices are substantially non-inferior, and these are the default device to place in a young person who needs this. Why is there this widespread consensus? It feels a little bit like you, Bogdan, and you and Bogdan's concerns are kind of being minimized or not really amplified at all in the community. I mean, and I bring it up because I said, this was done at a tertiary care center. This SubQ ICD was placed in a tertiary care center around us, and by one of the chiefs of EP, a senior guy in EP. So it seems that and there's no discussion even about the fact that this may be a potential downside of it. So I don't know. I'll get John's view first in terms of why that's happening. Why are you being ignored in the U.S.? And then I'm curious to hear from Bogdan if in Europe, if there's a different conversation that's taking place, maybe because incentives may be different.
Well, first of all, Anish, the Praetorian trial was published in August of 2020. It wasn't really that long ago that this trial was published, and so but the device had been approved for many years before that, and so there's this as well as I do that there's therapeutic enthusiasm for these devices, and so until August of 2020 there wasn't even really any notion that this SubQ ICD may be not inferior. And then in terms of just critical appraisal, I mean, the device is in the guidelines. It has theoretical advantages. It has marketing. There's intense marketing. There's also this sort of what's new is fashionable, and so I just think there's a lot of momentum. And when you get into what Bogdan and I pointed out about adjudication of shocks and non-inferiority margins, I mean, that's pretty in the weeds. That a lot of docs don't go to. And then my final comment is that, you pointed out that this is a tertiary referral center. Don't forget what tertiary referral centers do. Tertiary referral centers do lead extractions, and they see some of the worst complications. And so their sort of exposure bias or whatever the bias is, adjacent bias. I mean, they see the problems, and so along comes this device that doesn't have these, and they're like, yeah, we're all over this.
Bogdan, is I noted that, in a tertiary care institution, it was kind of, interesting that they didn't even mention the fact that there'd be more inferior shocks. And you would think that at a tertiary care institution, especially, and I assume this is emblematic of most tertiary care institutions in the United States, and that's my feeling, in discussing this with multiple colleagues in the US. Is that the same type of I mean, I'm surprised that there wasn't that conversation that was taking place. John mentions that it's really in the weeds, but my goodness, you would expect electrophysiologists, especially at tertiary care institutions, to be in the weeds of this stuff, right? So are folks in Europe who are doing this more in the weeds and doing perhaps better than we are, at least in terms of discussing downsides with patients and talking about this?
I don't think so. I have the impression that the discussion, the debates, the way things are going are extremely similar in Europe with the US. And going back to John's point, I agree that the perceived benefits of an SICD come from good intent, come from benevolence, and come from actual fear of endocarditis, of intracardiac leads stuck in there for 5 years or 10 years, and then very difficult to extract in case of an infection. And I do agree with the fact that a subcutaneous infection is not as bad as a an infection in the pocket of an intracardiac device. So I totally agree with that. But more to the point, why don't more people discuss the fine details of such a situation? I think that so first of all, there's an issue of it's not comprehension, but the way the medical literature is discussed. So I mean, most physicians, it's not because of lack of willness too, but I think most people don't even have time to read more than the abstract of the New England Journal papers. So, and then when they read the abstract, it's very clear it's non-inferior. Non-inferior, every clinician practitioner interprets it as equivalent. So they're the same.
Yeah.
New England Journal says so. But then they have the next patient, they have to do their consultations, they have to do their interventions and so on. Going back just a little bit to the fact that the situation seems very similar in the US and Europe, it might not be a matter of direct incentives or the way we're reimbursed, because most of Europe is under a clear salary, most physicians, so there's not a direct financial benefit to implanting newer, more expensive devices.
So that's so interesting. Yeah, sorry, that's so interesting, right, John? Because part of my theory and what I was kind of asking you these leading questions was that, you know, I find in the United States that there's that the adoption, that the very successful health systems are the ones that adopt newer technologies quickly and get them rolled out very quickly. Service line, you know, you come in, you know, so the program, the robust program is the one that's doing, you know, 50 SubQ ICDs and 1,000, you know, transfusion ICDs, you know, a month. Those are the robust programs. You know, the programs that say, hey, wait a second, you know, this TAVR or you know, any new, of course, TAVR was, you know, is a technology that, you know, has a lot more robust evidence for it. But my point is that all these different newer technologies that are reimbursed by third-party payers to the tune of many thousands of dollars, right? For any regular cardiologist who's seeing somebody for a follow-up and is getting paid, you know, $80 or $90, right? Each procedure that's done in the EP lab, right, is grossing, you know, paying by Medicare sometimes, you know, $30,000, $40,000, right? So it seems pretty obvious why, why a tertiary care system, whether it be a tertiary care hospital in the United States or whether it be a community hospital in the United States, that there's not a lot of time to be asking these kind of questions that is going to delay the rollout of these things, because that you do that, and you basically, if you are a program in the United States that isn't adopting some newer technology that's reimbursing a significant amount, you are suddenly losing out to the system next door that is. And that seems to be a very, very powerful incentive to not look for the downsides of new technology. But that's my impression in the United States. But again, the counter, of course, is what Bogdan's saying. Bogdan's saying is that the problem may be even more systemic than that. I mean, here you have salary doctors in Europe that don't have those type of incentives. And, you know, they're just not reading the trials. They just don't have enough time, and they just want to do the procedure or just follow the guideline that you know, that basically comes from the abstract and just move on. So is the problem more systemic, or what do you think, John?
Oh, I think, you know, Anish, I think the incentives are extremely complicated. It would be sophomoric to say that it's purely financial in any of these things. That doesn't mean financial conflicts of interest aren't important, but I mean, I remember when I first started looking at these things, I think there's studies from the VA showing there's just as many inappropriate stress tests at the VA, which is a capitated system, as there is in private practice. And so I think it's a combination of, like I said, good intent, therapeutic fashion, guidelines. And, you know, remember that electrophysiologists, I mean, I don't want to generalize, but in general, we like new stuff, and we like to be on the cutting edge, and one hospital likes to be doing things, but then the other complicated factor is now, like you mentioned, service lines. Our hospital doesn't do left atrial appendage occlusion, not because I don't think it doesn't work, but because it just doesn't work from a service line perspective. It wasn't gonna be a financially feasible thing for us to do in our little community hospital. So there's really complex drivers.
Can I be the devil's advocate here? Because we're working on the assumption that the SubQ ICDs are inferior. You mentioned some trade-offs, and I think the trade-offs are real. But at the end of the day, I mean, how do you parse whether the trade-off is worth it or not worth it, right? I mean, if in the long term, over 10 years. So, and to be clear, I think you and John and Bogdan, you called for a moratorium, right? You called for in your paper. You asked for just these SubQ ICDs not be implanted for a while until there's more data and that sort of thing. But I mean, it's possible that people are aware of these limitations and they just they view it differently.
Yeah, I mean, I haven't put in. I don't think I've put in a SubQ ICD since Bogdan and I wrote our letter with Rita, and then our point counterpoint and Jackie P. I mean, I'm very concerned. Just getting into the weeds, I'm very concerned that this device is inferior to the transvenous ICD. But I would also the trial. The trial, this is a big problem with a lot of cardiac trials. It went for, I think, 49 months. So, 4 years. But one of the biggest problems with transvenous ICDs isn't in 4 years. It's in 8 years and in 10 years. And so there's a great deal of uncertainty. And I can't say that putting in a SubQ ICD in a super young patient for a VF kind of situation is wrong. I was never a big implanter of these. I did them. I was cautious with them, but I mean, we have a standard device that has been tried and true. And this SubQ ICD really has signals of problems. So yes, it's complicated.
Right, and I think the simple, simplifying it to be, I think, it's a systemic issue where if you simplify it to be, you got this easy to implant device that is basically essentially that is equivalent to the transvenous ICD. It kind of leads to this path of least resistance where patients just get that, right? I mean, it's not that we haven't had young patients like congenital hearts, et cetera, that have needed devices, and we haven't come up with other better long-term strategies for these patients, right? So, I mean, I think Michelle's point is very correct that you need to have this discussion of trade-offs. And my point is not so much that, hey, let's put a moratorium on and not ever have this placed, because I don't view the FDA similar to a lot of folks in terms. I think the FDA in terms of its filtering, and what I would like is clinicians and docs to get in the weeds of trials and then discuss limitations with patients, and then kind of make the best decision for patients, and not have the FDA kind of arbitrarily decide whatever based on whether it be on vaccines or whatnot. But that's a longer and a broader discussion of scope. But I think what's really concerning, what John and Bogdan are bringing up, is that there may be a deeper systemic problem in how physicians are evaluating evidence, and the whole move towards NEJM, LBCT, these splashy PR things that come out. It's resulting in doctors just being like, doctors basically becoming New York Times readers, right? It's like you read the New York Times headlines that says, hey, aspirin is bad, don't use it. And suddenly, based on that, doctors are doing it. I mean, that's not what doctors should be doing. Doctors should be reading the RCTs that came out 5 years ago, and then agreeing, and then making up their own minds about whether or not aspirin or ICDs, et cetera. And I think that's the deeper systemic problem. Like, we just, how are you as a physician supposed to even have this conversation about, which is and make this shared decision, or even Michelle's going to come in now on the shared decision part. But how are you even able to intelligently talk about this with patients if you're not doing the homework that you need to be doing?
I totally agree. I just want to add one more point here. I do think this is more complex, and this is a systemic problem issue. And So the way I read this, the design of the Pretoria trial, the intention of the sponsor, who is the maker of the device, is that they were aiming to extend the indications in the guidelines. At least in Europe, it would be like this: you get an RCT positive, and then the next refresh of the guidelines would put it up at a class 1 indication with a larger indication. So all after myocardial infarction, low ejection fraction. I think it's almost the same thing that happened with the VEST trial, which was not a positive, let's say neutral or negative or whatever trial, where the intent of the trial was to extend the indication of the life vest towards a greater population and to get them in the guidelines. That's in the case of the life vest, that didn't happen exactly. But still, there's a push, I think, with those key opinion leaders we like to hear about, where they either present a post hoc analysis, or they present the per protocol results, or something that makes it look good. And then most of the working class physicians, they get most of their education either through industry-sponsored evening events, at least in Europe, and the annual or biannual conferences, which are all, well, sponsored or not sponsored, it doesn't matter, but they're always the same key opinion leaders who talk about. So most of the education is key opinion leaders and guidelines.
Yeah. So, and this is the great point here. Like, we just had David Zweig on, the journalist who has written some wonderful articles on COVID, and he brought up a similar point when it comes to COVID and how it is that consensus is being decided upon. Consensus is not some 150, 200 people, all this, who are all, from all parts of the country, all parts of the globe, coming together and saying, hey, this is what we think this is what's reasonable. And that's what drives consensus. Consensus seems to be now based on a very tiny fraction of folks who are saying something, have a wide megaphone to popularize it, and suddenly that becomes consensus. And you see it with COVID. Oh my goodness, it's so obvious with COVID that you see that consensus, this fake consensus being created. And it's probably a much wider problem that has been going on for some time. That, Bogdan, it's a great point that you bring up, that it's these tiny fraction KOLs that and I think everyone realizes, if you get to those if you get to those KOLs and get the KOLs lined up for whatever reason, then you have a consensus. And then the real problem, though, is what the heck happened to the physician community that we just blindly accept?
No, the real problem is what happened to evidence-based medicine that was supposed to do away with the influence of KOLs. You're going to have evidence-based medicine, a revolution started in the 1990s, clinical trials, analysis, meta-analysis, systemic reviews, and then you wouldn't have any fake influence or influence of
John
but here we are.
EBM, yeah, John, has EBM been captured? Is this an end around?
There's no question. I think there's a very famous article written how EBM has been hijacked, and so you can definitely spin these trials. But one of the things that pushes me in the last decade to write and to understand these trials is just to sort of teach the world through social media and YouTube and Twitter and blogs to teach these tricks so that doctors are less apt to be bamboozled by things. And many of the medical learners that have spoken to me say that they don't get much of this in medical school, and I'll get an email that says, "Hey, Mandrola, where do I read how do I know what you know? Where do I read this? And where's the instruction manual?" And there really isn't an instruction manual for figuring these things out. And my hope is that through long form content like this, and I would also point to the emergency medicine community. They have oodles of blogs and podcasts, and they dissect these things down, and they're amazing, and they've been leaders in this. And so I just think we need to arm our colleagues and our learners and with this knowledge so that they're less apt to be fooled by some of these tricks.
Right. Okay. So I've been banging a lot on the cardiology community a little bit in the first 25 minutes. But I got to say, the cardiology community is probably the most robust in terms of this kind of discussion and that happens, right? And so, unlike other venues that John has entered recently, I mean, there's a robust conversation that's encouraged, right? So John and Bogdan and Dr. Redberg's a letter to the editor on the Praetorian trial is out there for everyone to read. There was a fantastic Jack EP back and forth between those who are pro, keeping the SubQ ICD, the pro argument in terms of SubQ ICD and the argument against that. That was again by Bogdan and John. That was just fantastic and really nicely goes through that. So I think the cardiology community should be seen as perhaps the vanguard in terms of where you want to be in terms of allowing some of these robust discussions to happen and to happen not just like in private blogs and some underground signal conversations, but happen in the peer-reviewed literature. So I got to say that it's been nice to see, and again, thanks to John and Bogdan for not just browsing in podcasts, but to actually go out there and do it. But it's also a reflection on the cardiology community being as vibrant as it is, that it allows that to happen, right? John's been invited to do John's always the villain in the cardiology conferences. He's always invited to do to take the other side, and I think that's really appreciated. All right. The other case that we discussed was the case of Michelle's patient who was an avid cyclist who had a true cardiac arrest, was like getting CPR for like 25 minutes for VFib or VT, and then has declined a defibrillator for basically out of hospital cardiac arrest for secondary prevention, something that we generally never see happen. And that was a totally fascinating case, and we brought John on because part of the reason he said I'm not going to do this is because he read John's book. Again, nice book, a great book John's written, Haywire Heart. not what John wanted when he wrote that book, for sure. But he came in waving John's book to Michelle, saying, look what this guy Mandrola said. Bogdan, what did you, I don't know if you, I hope to not put you on the spot. I don't know if you had a chance to listen to that case. What were your thoughts listening to that case?
Oh, I listened to it twice. It was a very good conversation. And so to get it out of the way, I would also agree that not only do I consider John to have an indication for a defibrillator of any type, but more so, I would feel that were he my patient, I thought to myself, I would actually have actively tried to persuade him, and then come all the philosophical questions. I mean, is it my duty to persuade somebody? Is it my duty just to inform? What does inform mean? I'm gonna tell him my opinion, but if I see him hesitant, should I try to convince him? Should I try to bring counter arguments to every argument he brings to the table? It's a fascinating episode, and I've been reflecting upon it a lot.
So Bogdan, in the US, and John, correct me if I'm wrong, but CMS, at least for Medicare patients, CMS requires, I think they passed a regulation. They require doctors to enter with their patients into quote unquote shared decision making before implanting a defibrillator, perhaps at least in primary prevention. I'm not sure exactly the context. In primary prevention, maybe not in this case, but nevertheless. So shared decision making is it's what's the term? I mean, it's such a lofty and praiseworthy ideal that I think it's, to me, I think it's a great indignity that is being foisted on doctors, and we blithely and naively accept this concept of shared decision making, at least in the US. Has it? Do you have that in Europe too? Do people talk about shared decision making? When I looked into it, I thought actually I saw quite a bunch of. I mean, that is fairly widespread. this idea of shared decision making?
So it is widespread. I think it's rarely in a formal manner. So,
right. I think part of it is because it's an incoherent concept. For the reason that you essentially alluded to, what does it mean to make a decision? I mean, how do you distinguish shared medical decision making from informed consent, right? I mean, the patients obviously have to consent to the person. You're not going to strap that guy and implant an AICD against his will, and he has to consent, and he has to provide an informed consent, which I think is the right ethical stance.
Australian public health would absolutely
right
strap him down and implant it.
They would, but in the civilized part of the world, I think it's correct that you want to inform the patients, and perhaps we can talk about the distinctions or between informed consent and shared decision making. But John, so you said that you don't implant SubQ defibrillators anymore.
I haven't done it since the.
Since you published.
Since the trial, and it
right.
just hasn't come up. But I have put. Yeah.
Do you inform? I mean, say somebody needs a defibrillator, and do you inform them of the availability of SubQ SubQ defibrillators, and then how do you let them? How do you do the shared decision making part?
I mean, I go back to when I got my shoulder replaced many years ago. I shopped it around. It was kind of a complex reconstruction, and I went up to see the Indianapolis Colts doctor, and I'd read so much about it, and I asked him, what kind of technique are you going to use to fix it? And he goes, you just have to decide whether you want me to do it, and then I'll do it how I see best. And so it kind of like, the type of pacemaker, the type of ICD, yes, I would go into some of it, the leadless pacemaker versus the wired pacemaker, but some of these details, it's just a judgment call about how much detail to go into. But for sure, I would consider an ICD a preference sensitive decision, and I would have a discussion about the positives, the negatives, the expectations, and what if you do nothing. And so all that is part of my discussion of almost any EP procedure.
Right. But if you have a patient who comes and waves at you the last prospectus from the SubQ ICD pacemaker and say, I really want this, I don't want anything in my veins, would you give it to me? And then if you firmly believe that it's inferior or not, what do you do?
Yeah, that hasn't come up, and I guess it could come up. I'd have a discussion, and then I on a case-to-case basis, I decide. I'm sorry that sounds like a platitude, but it's just truthful.
Right. Yeah, it is. I mean, so I mean, the whole thing about shared decision making, I think either one of the two parties submits to the other's decision. Right. Yeah, and normally it should be that the patient submits to the doctor's decision, because it's impossible for the patient. Otherwise, they're not really patients. Otherwise, they.
Yeah, but I think you're too triggered by this, Michelle. It's not that bad.
Very triggered.
It's just like Dan Malek says. It's just a meeting between two experts, right? The doctor is sort of the expert in all the medical technology and that business, and the patient's expert in what they want. And take anticoagulation for stroke prevention. Some patients really fear stroke. They're just so scared of stroke, and they're willing, they're going to take anticoagulants. But other people are just, they've had a friend who've had bleeding, and so for them, they're afraid of bleeding. And then so you have this meeting of the experts, and what I try and do is come to a shared understanding of everything, of medicine, uncertainty, and come to the best decision for that patient. And it's normal doctoring. It's not special.
Well, but and I'm triggered because it's not. So what you do when you take into account your patient's psychological makeup and their preferences, you actually are being a doctor. But it should be your right. It's still a medical decision, which is yours as a doctor. So the reason I'm saying, because I'm very sensitive to, the culture that is trying to be instigated by those who push things like shared medical decision making, it's actually destructive to the doctor-patient relationship, in my way. And if you read the literature, that's exactly what it is. It's a bunch of bioethicists, or some of whom are doctors, but they're that really want to quote unquote elevate patient autonomy in a way. I mean, that's the idea, and diminish the doctor's prerogative, which distorts the relationship. And then they got a boost. So they introduced the concept of shared decision making was introduced in the 1980s, and it died. Nothing happened. There was a big presidential ethical commission that said, really, we should have shared decision making because, you know, doctors know too much and they don't give enough leeway to patients to decide for themselves. And they thought that was bad. And then it died, and it was resuscitated when EBM came around, because all of a sudden, now you have EBM. Now the patients can be armed with the knowledge that the doctors have. So then it becomes a public knowledge. EBM becomes a public knowledge, and the patients can, you know, sift through the meta-analyses and whatnot, and then decide for themselves. And the doctors is essentially just an information provider. And I think that's really wrong. That's really wrong. So maybe I'm splitting hair, because I think in practice it doesn't work. And fortunately, it doesn't work because it's so unnatural and contrary to what happens in medicine. Patients don't want to make those decisions most of the time, and they shouldn't. I mean, the meaning of patient means that you don't have autonomy. I mean, that's what patient means. It's the opposite of agent. Agent and patient are the antonyms. And so I think we need to keep our antennas out for these kinds of. They sound always, you read in literature, shared decision making is great. We're going to be partners with our patients. What could go wrong and whatnot? But at the end of the day, it's trying to undermine the doctors, undermine the profession, undermine our autonomy, undermine our decision making, and there. That's. I'm getting off my soapbox here.
I think John has written an article about remember Daryl Francis, about, for instance, statins comes up, right? Like, who should get on a statin? Like, you know, and the way we interpret guidelines, you know, 80-year-olds get put on statins who haven't had any events, you know, for primary prevention, right? And is it worthwhile arming patients with some information, especially given given the fact, Michelle, that we just outlined in that first case of Tom, that the doctors aren't reading the trials? How do we arm patients with some information so that we can kind of put in these road bumps or speed bumps to physicians that maybe are not?
You know, at the end of the day, either you're a good doctor or a bad doctor. If you're the good doctor, you read the literature, right, and you do your best. And if you're a bad doctor, you can maybe punt and then, you know, give patients, right? I
think John, Daryl, etc., Bogdan said they can be viewed as trying to give patients information to protect them from bad doctors. Like, maybe, I mean, if Tom Wingert had read John's blog about John and Bogdan's blog about, you know, SubQ ICDs and inappropriate, maybe he would have asked the question.
Correct. So it tells you what a sad state of affair medicine is, so that we have to get around, right? And we can't even educate the doctors. We have to go ahead, John.
Let me just say that patient, the way Bogdan and I went about it, our critique of Praetorian was all behind a paywall, right? So a patient's not going to be able to read New England, our letters to the editor. They're not going to be able to read Jackie P. And had we done a podcast, or had we done a YouTube video or a blog, then that, or written a book, that would have been accessible. So we went about it in an academic way, but that's not necessarily the only way. And to go back to the shared decision-making thing, the thing that I like about the movement towards shared decision-making with defibrillators is this move to use decision support tools. I really think decision support tools are important because they lay out for a patient they lay out the pros and cons, and one of the problems with accepting these decision tools is that it's actually pretty small incremental benefits of some of the things that we do. And when patients are truly informed about, how much risk reduction they're going to get versus how much harm they could potentially get, then they will sometimes make decisions that aren't exactly what we make. And so I'm totally okay with that. I'm never upset when a patient comes to me with a Google search and all of these meta-analysis. I'm like, I've already seen them. Or if I haven't, I'll say, look, I haven't seen this. I need to study this. So
right.
I like the idea of patients being armed with information.
So for the audience, what you're talking about, these decision aids, they usually tend to be graphical, sort of graphics where it shows how many patients may benefit, in terms of percentage, and you have, so that visually a patient can understand the trade-offs, so to speak, between the benefits and the risk with the intervention, without the intervention, and that sort of thing, and come up with a decision. But I mean, that's fine. I mean, if we want to take, I mean, we live in a culture where autonomy is such a high praised value that I mean, it's hard to go against that grain. But at the end of the day, my point is that then it becomes their decision. If it goes against what you would recommend, then it's their decision. It's not a shared decision. Right? It cannot be a shared decision. It's either they decide and then you say, okay, well, I don't feel so strongly and I'm going to submit to their decision.
No, but it's a preference sensitive decision. I tell patients all the time, in EP, almost everything we do is preference sensitive. So I say before we even start, I'm like, this is a preference sensitive decision and different people feel differently about it. And so if they decide against an ICD or against anticoagulation or whatever, then it's not against me because I start the whole conversation with the fact that this is preference sensitive. We're not talking about, antibiotics and sepsis or, insulin and diabetes. Yeah. We're talking about 1 or 2% absolute risk reductions over the course of 5 or 6 years, whatever.
But John, but here we're talking about defibrillators, which, could mean life and death. And, it's not, it's a little bit unlike the statin thing. And, I'll give you an example. So I wrote in one of the pieces that I wrote against shared decision making, I talk about going to a conference and an EP conference where the speaker goes and tells a story, and he's very proud that he engaged in shared decision making with this young woman who had a cardiac arrest. And they talked about the pros and cons and went through the whole thing, decision aid and blah, blah, blah. And then he said that, and at first, because the young woman eventually refused, I think it was a QT prolongation case. She refused the AICD. And at first the family was not on board, but after a lot of wrangling and discussing, the family came around and they became on board. Well, maybe they became on board at that point. But suppose that, later on, maybe she has another cardiac arrest. I mean, it's hard. Maybe if the doctor truly believed that an AICD was indicated, and then makes it sound like it's their decision or it's a kumbaya decision of everybody, and then something bad happens, who takes responsibility? Then nobody takes responsibility because it was all a kumbaya decision that we all took together. And I think that's kind of a masquerade of what really should take place, should
John,
be happening.
John, what do you think about the CDC data visualizations that when it comes to vaccine risk benefit, especially when it comes to young boys? It seems pretty obvious based on the visualizations that everyone should be getting vaccinated, especially young boys with 2 doses, no?
So I'm trying to recover from almost being canceled, to my whole brand tarnished, and Anish wants to drag me right back in, and I refuse to answer that question. Bogdan can answer.
I'm going to save John's cancellation. Just to save John's cancellation, I wanted to add something with the shared decision making, either shared or not, consent, informed, signed, whatever. I think one of the words, the concept that floats around all these discussions, and I love Michelle's posts and for earlier talks about this, is the concept of trust and mutual trust between the patient and their doctor. And I think this is something that bioethicists don't have, public health rarely has, and this is one of our really benefits, and we really should cherish this, the one-on-one mutual trust, that the patient trusts me, and that's where we get to some parts of the decision where we don't discuss every type of tool I use, the stitch, the lead, the type of lead, active fixation, passive fixation, and so on. They trust me, and I trust the patient as well, that they're not a complete bozo who wants what's worst for him or herself and their family. And going back to John, the patient, we have to trust him that he doesn't want his wife to suffer. He doesn't want his daughter to have to be left without a father. She's grown up, I imagine, but still. So I think mutual trust is something that should always come up in this.
Amen. Amen. I think that's a really great point, and I think that's what's undermined by these bioethicists who view the doctors primarily as technicians. Right, they view the doctors primarily as technicians. They want the patients to have more autonomy in the decisions, and then they came up, they constructed this shared decision making. John, you want to have one last word on this?
I don't think that shared decision making. I don't think that these decision tools undermine trust at all. But I do agree that I agree. First of all, I love Bogdan's point about trust. Is that's the essence of it, but. The decision tools, I just don't think shared decision making undermines our trust, because it just gives the patient maybe enhanced trust. So I guess I don't even think we disagree that much. I think we're both talking about good doctoring.
Right.
Just to finish my point, I don't want to. This was not an argument against, well, neither for. It's just to change the perspective and the recenter it.
Yeah, I think I think you're right that we don't disagree that much, because intuitively, I think, John, you're doing the right thing. Well, I'm aware, because I've read the literature about shared decision making. I've read the arguments that the bioethicists came up with and their intention, and I know how they operate, and I think it's overall damaging. It's an argument that assumes the fragmentation of care, assumes that doctors and patients don't know each other, assumes all these things, and perpetuates all these problems, neglects having understanding what the root of the problem is, assumes all these bad things about the fragmented healthcare system, the financial incentives that are present and so forth, and want to remedy them with these contrived notions of shared decision making that at the end of the day don't make much sense.
I'm gonna wrap up by asking, by trying to link the discussion so far with what's the type of conversation that has been going on related to COVID and mandates and NPIs and whatnot. Does it seem to, and I want both of you to kind of think about it and answer based on your perspectives, from different places, different across the pond. It seems that public health has, the conversation has shifted in terms of the risk we allow people to take. Is it, it's now gone to the point where, well, if it's the case that NPIs and different things that we've done that have clear costs, right? Whether it be masking children, whether it be keeping small businesses closed, etc. But if that results in net fewer flu deaths or net fewer whatever deaths, that it is okay to kind of subsume the rights of patients to make decisions for themselves, right? You can see an extreme version of this when it comes to people, surprisingly, on the left, saying that, well, if you're unvaccinated and you now show up at the hospital struggling to breathe, there's a coterie of angry people that say, you know what, they should pay for it, or they get put last in the line when it comes to needing a ventilator or needing support. Are you too troubled by where the conversation in terms of what many leaders in medicine are kind of having and with regards to this, and does that have anything to do with conversations that we have been having in terms of putting patient autonomy really front and center to allow someone like John, who's resuscitated from cardiac arrest, to say, you know what, I don't want a defibrillator. I don't even want a life vest because I'm not going to be able to fit into my tux for my daughter's wedding. And God forbid, you're gonna not, not allow me to go to my daughter's wedding. I mean, we've traditionally been in that place, certainly in the United States, where the patient has a tremendous amount of latitude in terms of what they can and can't do. And it seems like we've really gone very, very far from that in this emergency that has lasted now 19 months or whatnot. Are you concerned about where the conversation may be heading with all these things, John and Bogdan?
Bogdan, you go first.
So I'm concerned by, I have conflicted thoughts on everything. What I can clearly say is that trust, to go back to that, is being lost. I think a lot of public health, though, like the world of public health, lost the trust of a part of the population, perhaps increased in trust in a minority, perhaps. I think there are lots of things which will stay with us for a long time regarding the way we interpret uncertainty and risk. I mean, we're talking risks of 1 in, let's say, 50,000 to whatever, on whichever side of the debate. And to go back to our one-on-ones with our patients, when we talk about a procedure or an AF ablation or something like that, we talk about risks. Let's say we say 1%, and the patient goes, "Oh, that's nothing, doc. All right, book me for the intervention." And it's just the difference in order of magnitude, to not even go into the direction of safetyism and Coddling of American Mind book and everything. Things are going on and things are changing. For the long run, I don't know. I'm not sure.
Because so John, to put a firm point on what Bogdan is revolving around, it seems kind of silly in the fall of 2021 when public health has given these mandates. Right? Like, you do not have the option of your 4-year-old not being masked. I'm sorry. Like, everyone has to be masked. How can we have is it possible to be having a conversation about shared decision making now, given that it seems like public health has zero interest in shared decision making?
Well, Anish, you're persistently trying to drag me into this. I guess I'll say a couple things. I wrote a couple notes down. Number one, the pandemic has been a great trauma. So if it's been a great trauma for the globe, for people, for families. It's just been terrible. And so there's that, right? So we've just recovered from this trauma. The other thing is that a lot of our preference sensitive decision making that we make in the cardiology clinic is for non-communicable diseases where, John's decision not to have a defibrillator, it doesn't affect anybody else. So there's that. And then, when the pandemic started, I always came at it as this doctor-patient relationship. So when I see patients in the clinic, I do what Bogdan does. I try and build trust. And I discuss uncertainty and I allow for preference sensitive decision making. And so I always approach the pandemic that the public health folks were like doctors and society was like the patient, and they would build trust and it would be sort of this analogous relationship. But this didn't work for me. This didn't work, right? Because of the great trauma, because of the infectious pathogen. And so I've come to the view that it's probably going to be, I've come to the pragmatic view that we just have to wait and hope that in a few months, as cases go down and immunity goes up, that sanity will come back and the trauma will be farther, the trauma will be in the rear window, and then we can have more rational discussions about risk.
Excellent. Folks, thank you so much for coming on. That was a fantastic conversation. It's wide ranging. It's hard to not bring the wider things of what's happening right now when we're talking about cardiology, but hopefully we can go back to, wrestling about cardiology without some of the aspersions that are cast when talking about what has suddenly become a third rail issue. So anyway, thank you so much for both for coming on. Really appreciate your time.
Thank you.
Thank you very much.